Hi and welcome back again. This is Dr. Ram Nair, Emergency Medicine Consultant and CEO of Jeevaraksha Trust. I hope you had a good introduction and assessment session of COVID, as well as an effective session on the oxygen therapy for patients with COVID. So here we are going to go through chapter 4, which is split into two sections. The first one is the medical management of COVID in adults, and the subsection 2 or 4.B will be the management of children with COVID. We will be covering mucomycosis in the adult section. So we had looked at the overview in the introduction slides. As we discussed, 81% are asymptomatic or very mildly symptomatic. The rest 19% require medical input, of which 14% is severe. And there's a 5% of cases which require intensive care unit management, and unfortunately 3% of the total succumb to death. So in triaging of COVID-19 patients, the clinical history, the clinical examination with vital signs, as well as taking into consideration the comorbidities is extremely important. And as you know, there is a percentage of patients who may not test positive in the RT-PCR, and at times of significant surge of the pandemic, anyone who is exhibiting symptoms should be considered as COVID positive and given the appropriate treatment as well as observations. Sometimes patients who do not have any symptoms or mild symptoms and with no warning signs can be considered for home isolation or COVID care center management and monitoring. If the warning signs are present, then we'll have to categorize the patient into mild, moderate, or severe and refer to the treatment protocol, which is going to be discussed shortly, for appropriate management. So home management is for people who are definitely asymptomatic or mild, and their oxygen saturation is more than 94%. We also need to have a look at their heart rate as well as respiratory rate. Heart rate below 100, so patients who do not have regular tachycardia, and the patients whose respiratory rate is below 24 per minute are considered to be safe for home management. Nowadays, unlike the first week, we are also looking at patients with comorbidities for home management as long as they have had a medical consultation and the physician has declared that their comorbidities are under control. And this includes conditions like high blood pressure, diabetes, thyroid disease, even cancer or kidney and liver or heart ailments. Recommendation for asymptomatic cases. There is no significant evidence for anything other than symptomatic support. So home isolation and care includes adequate nutrition, appropriate hydration, and vitamins and mineral supplements only if the patient is undernourished. You teach them to take a 6-minute walk test twice a day. This is covered in our non-healthcare volunteer COVID video if you're interested. And we ask them to measure their oxygen saturation and temperature every 4 hours. We provide counseling to the patient as well as family members through telephonic conversations, psychological counseling, and symptomatic medication where indicated will be provided. There should be a very low threshold for admitting patients with high risk features like a low saturation, higher respiratory rate, or comorbidities which are getting out of control. So the clinical guidance as they exist today for the management of COVID-19, the mild diseases are the ones with minimal or no upper respiratory tract symptoms without shortness of breath or hypoxia. The moderate ones are anyone who's got a respiratory rate more than 24 or a saturation less than 94% on room air. And severe disease are people who have got significant lung involvement and the respiratory rate obviously will go above 30 per minute and the saturation could be dropping below 90% on room air. The treatment protocol for mild cases includes for patients with uncomplicated upper respiratory tract infection with mild symptoms, fever or cough or sore throat or general tiredness or headache. So these patients should be exhibiting a saturation of more than 94%. If there is risk of severe disease or unstable comorbidities, kindly consider admitting them to an oxygenated bed. So the clinical guidelines are for mild disease. So I'm just going to cover home isolation, and I'm sorry for the busy slide with the table. If you just look at the left column, the precautions that need to be taken are contact and droplet precautions with strict hand hygiene, managing the symptom with hydration, antipyretics and antitussive medications, staying in contact with a trained volunteer or their treating physician regularly. So this is where the state or the non-governmental organizations will be providing telephonic counseling support to make sure that if there is at the earliest sign of things getting out of control, these patients can be referred to a medical institution. So where would you seek a medical attention? There, you should be referring these patients quickly if they have got difficulty in breathing, the respiratory rate is going above 24 per minute, the saturation coming under 94%, or the fever is not settling with regular medication, or the fever and cough is persisting after 5 days of the symptoms onset. There should be a low threshold to refer patients who have got high risk features. Now, what are the high risk features? Anyone who is older than 60 years of age, anyone who's had cardiovascular disease, including high blood pressure and coronary artery disease, diabetes mellitus, or any other immunocompromised situations, people who are suffering from chronic lung, kidney, or liver diseases, people who've had a stroke or any other form of cerebrovascular disease, and people who are overweight. Because we know all these high risk categories of patient do really poorly if they get into the moderate or severe categories. So continuing with the home isolation, if the fever is not controlled with a maximum dose of paracetamol 4 times a day, we should be considering the use of non-steroidal anti-inflammatory drugs like naproxen 250 milligrams twice a day. There is no significant evidence supporting tab ivermectin, so we are just putting it there as it is part of the national guideline. Chivarexa is not recommending tab ivermectin as there is no clear-cut evidence supporting its use in COVID-19. While inhalational budesonide, which is 800 micrograms through a spacer twice a day for 5 to 7 days in the beginning of the disease, if symptoms like fever and cough are persistent beyond 5 days, has got mild evidence support in keeping the lungs and the extension into the lungs under control. Systemic steroids is definitely not indicated in the bile disease. It could be considered only after 7 days, once the infective stage of the disease is settling down and the inflammatory stage starts, in consultation with a treating physician for a short duration of 3 to 5 days. And for this, you could use dexamethasone 0.1 to 0.2 milligram per kilogram once a daily, or if not available, go for methylprednisolone orally for 0.5 to 1 milligram per kilogram in 2 divided doses. Now we'll go into the management of the moderate cases. So these are the patients with some level of lung involvement, but no signs of respiratory disease. So they could have mild amounts of hypoxia, fever and cough. Respiratory rate will be between 24 to 30 per minute. So remember, they'll be tachypneic but not above 30 per minute. The saturation could be low, but between 90 to 94% on room air. So if it is going below 90, or if the tachypnea goes above 30 per minute, then we are looking at somebody who is having severe COVID with lung involvement which is extending beyond the lung margins. So the clinical guidelines as they exist currently for the moderate disease, of course, all these patients need to be admitted into an oxygenated bed for medical as well as nursing input. The target saturation for these patients under oxygen support is 92 to 96%. So mind you, we are not looking at 100% oxygen saturation. And for COPD patients, we are looking at a target of 88 to 92% saturation with oxygen support. The preferred devices of oxygenation in these patients is non-breathing face mask. So these are the ones with a non-breather bag, which will give them a reservoir of about 500 ml of oxygen as they take in a breath. Awake proning should be encouraged in this situation. There is significant evidence to support proning when the patients are awake, changing the position every 1 to 2 hours. Now, what is proning, how to do it both in ICU as well as non-ICU patients is covered in our respiratory rehabilitation slide set. We also could start them on the anti-inflammatory or immunomodulatory therapy. So here we'll be going into systemic steroids injection. So either methylprednisolone or dexamethasone. If you're going for methylpred, 0.5 to 1 milligram per kilogram in 2 divided doses, or dexamethasone 0.1 to 2 milligram per kilogram per day for a duration of 5 to 10 days. Again, these are short course of steroids to counter the inflammation from the illness. As you know, most deaths happen because of body's uncontrolled inflammatory response to the COVID virus. The patient could also be initiated or switched on to an oral route if they are found to be stable or improving. There is a high incidence of clotting related casualties in COVID patients, and we should be using some prophylactic anti-clotting medication. So according to weight of the patient, you could give enoxaparin 0.5 milligram per kilogram per day in a subcutaneous dose. The monitoring for these patients will be primarily looking at their work of breathing, their hemodynamic instability, and if there is significant changes in oxygen requirement. Serial X-rays are required if their symptomatology is getting worse, and high-resolution CT for the chest should be only done if there is significant worsening of the patient. For lab monitoring, you could rely on CRP and D-dimer every 48 to 72 hours. Also, we could be using CBC, RFT, LFT every 24 to 48 hours, and if available, interleukin-6 levels, and this only if the patient is deteriorating significantly. If the patient is improving, you can discharge the patient as per the latest revised discharge criteria, which is in our website for the state of Karnataka, or you could look up the national guidelines for discharge. So the investigations, just quickly covering them again. So total count, differential count, TLC trend, electrolytes like sodium, potassium, as well as looking at lactate and the oxygenation through an arterial blood gas monitoring. Blood urea and creatinine to look at the kidney function. Inflammatory markers like C-reactive protein, looking at ferritin and D-dimer, liver function tests, LDH, and ECG if there are any cardiac symptoms exhibited. You could repeat CK, PT, APGT, INR, and chest X-ray if indicated. So the treatment of moderate cases, you could include antibiotics if the patient has a secondary bacterial infection, and for that you'll be considering either oral azithromycin if it is a mild infection, or ceftriaxone 1 gram IV BD for 5 days for a more severe infection as per the HIC protocol. There is no recommendation for nebulization to be given in the wards, as it generates too many aerosols and is a higher risk for the treating physicians and other staff. Now coming into the clinical guidance for management of severe diseases, this is a place where the patient would require significant respiratory support, continuing immunomodulatory therapy with higher doses, and continuing anticoagulation. So for the respiratory support, consider the use of non-invasive ventilation or high-frequency nasal cannula in high-flow nasal cannula in patients with increasing oxygen requirement if work of breathing is low. And here the humidification of the oxygen also come into place. Intubation should be prioritized in patients with high work of breathing if the trial with NIV is not tolerated. Earlier intervention with intubation for patients who are struggling to breathe has proven to be more beneficial in COVID patients. So use the conventional ARDS net protocol for ventilatory management. Immunomodulatory therapy, you are going to be giving slightly increased doses of steroids, so 1 to 2 milligram per kilogram of methylprednisolone given IV in 2 divided doses, or Dexa 0.2 to 0.4 milligram per kilogram for a duration of 5 to 10 days. Anticoagulation will be continuing as discussed before to prevent the side effects from blood clots. Supportive measures here, normally in sepsis we tend to recommend huge amounts of fluid to keep them well hydrated. In COVID, we are looking at euvolemia because in severe cases there is evidence to show that quite a few of these patients go into renal failure. So maintain euvolemia, and if sepsis or septic shock is detected, manage as per the local protocols and the local antibiogram. So we're looking at what is the pathogen and hitting it with their resistance or otherwise profile after the culture. Till then, these patients will be getting your injections of ceftriaxone, which has already been started as recommended in the previous slides. For monitoring, you can use serial X-rays or high resolution CTs if the patient is deteriorating. You can be using CRP and D-dimer as discussed before, and the other blood tests. And here the interleukin 6 levels are useful in monitoring the patient's progression. Now, to talk about a drug which has been used widely in India, this is another immunomodulator where if there is a presence of severe disease, and preferably in the early stages, so within 24 to 48 hours of the onset of severe disease or intensive care unit admission, and in the background of significantly raised inflammatory markers like CRP or IL-6, and the patient has been on steroid therapy and there is no significant improvement despite the use of steroids, and also making sure that there is no active bacterial, fungal or tubercular infection, you could use this highly immunosuppressing medication called tocilizumab at a recommended single dose of 4 to 6 milligram per kilogram in 100 ml of normal saline over 1 hour. I repeat, as a single dose. And this is an experimental therapy. There is no strong evidence recommending it for all patients. So please be careful in choosing your patient category, and early intervention in the right kind of patient might give some benefit in managing severe COVID patients. Now we're coming into a recently noticed entrant in the COVID spectrum. So even though Mucomycosis was reported during the first peak in our country, this time we found that there are significantly higher number of cases. So let's look into what it is and how to manage it, and most importantly, how to recognize it early so that we can save vital organs and useful organs and leave the patient with some quality of life if they manage to survive a rampant mucormycosis infection. Mucomycosis, as you all know, is a fungal infection spread through spores. It is found in very high density in India, unfortunately, due to the climate and other factors like hygiene and presence of biomatter everywhere. Important thing to notice is the median of the presence of mucormycosis infection is 11 days after discharge from COVID hospital. So you would be managing patients regularly with no problems and managing only COVID. They get better, they are happy, you are happy, they go home, and the illness hits them 10 days down the line. So that is the time to keep an eye out for mucor. So from your perspective, when you're discharging, doing a quick ENT examination, as well as giving them advice to what to look out for, particularly in patients who've had a high blood sugar level, is vitally important in picking up this disease early and making sure that these patients are managed successfully. It attacks through the vascular endothelium, and the microthrombi found in COVID in large numbers facilitates the spores to flourish in a COVID patient, and that is why we believe there is such a higher number of mucormycosis in patient who has had severe COVID. It is predilected in COVID-19 because of immunosuppression, because of COVID itself, rampant use of steroid therapy in the first week of COVID, which is generally not indicated. The higher blood sugar in COVID patient, whether they have got diabetes or even otherwise, we found that the blood sugar is running high in most COVID patients who have got moderate or severe spectrum of the disease. So an HbA1c of above 9 is a predictor for higher incidence of mucormycosis. Microemboli, as we discussed in the last slide. Higher ferritin levels because the fungus prefers iron, and there is a theory that the zinc therapy, which initially was recommended with hydroxychloroquine in our country, Now that people have stopped using hydroxychloroquine, people have forgotten to take zinc off the polypharmacy prescription. And because quite a few patients in our country are getting zinc therapy in the first week of COVID, there is a theory that this is the reason why we are finding more Mucor patients in India, as it promotes the fungal invasion. So what are the symptoms? If you think about Mucor, it is usually and commonly hitting the upper respiratory tract and getting into the nasal sinuses. So it presents as something which is similar to a sinusitis with exaggerated symptomatology. So they might come with nasal blockage, discharge, but interestingly, local pain and swelling over the area where the infection is happening first. And if you examine the patient, there could be a black discoloration over the nasal bridge, palate, periorbital region, mucosa. So looking inside the mouth, looking inside the nose, and examining the eye is very important as a screening examination for mucomycosis. The patient could quite often complain of intractable headache if it is extending into the sinuses or even beyond. Loss of sensation or numbness over the infected area is a commonly described symptom, and if it is affecting the eye, blurring or loss of vision is also reported commonly. So again, to repeat, looking at the oral cavity, looking at the nasal cavity for early signs like inflammation, local swelling, local tenderness, local numbness, black discoloration. And when the patient presents after COVID, say on an average 10 to 11 days after COVID, and they're complaining of sinusitis, or even if you're a telephonic volunteer or a teleconsultation medic and you're calling up and they're mentioning these symptoms, please have a high index of suspicion that this could be COVID and refer them along for an examination. The tests that are recommended is either MRI or CT-PNS with brain contrast study for the orbital and sinus involvement of, and as well as the brain involvement of mucomycosis. What is ROCM? It is rhino-orbito-cerebral mucomycosis, which is the commonest form of mucomycosis which is found amongst the COVID patients. There are other less common mucor infections like the pulmonary one, gastrointestinal or disseminated mucomycosis. Very, very rarely you could get a direct cutaneous involvement of mucomycosis too, but the cutaneous one is much less dangerous than the others mentioned before that. What is the treatment for mucomycosis? So this is one condition which is best managed as a multidisciplinary team. Because you've got multi-organ involvement, you need an infectious diseases expert, you need a microbiologist, you of course need an ENT and an ophthalmology surgical input at times. Sometimes you might even need a neurosurgical input. And of course the COVID specialists who are treating the patient and the intensivists who are looking after the ventilation, the anesthetists getting them to theatre and back. So it is a large number of people, and given the higher levels of dressing involved, if there is debridation, it is important to train your nursing staff also accordingly. So what would you do from a medical management that has been going on so far? It is important to reduce or discontinue steroids as soon as possible. The blood sugars should be controlled. As we discussed before, higher blood sugar creates a better environment for rampant spread of the infection. So insulin infusion for hyperglycemia is important. Discontinue all the other immunomodulators as well. And if there is necrotic tissues in your CT or MRI scan, extensive surgical debridement of these tissues is important in arresting the spread of the infection. For the medical treatment, there are a few options. If you're going for amphotericin B, choose the PICC line as an option to be infusing this drug. We have to obviously monitor the renal function closely as it is a nephrotoxic drug. So for the same reason, this is a place where we will say keep the patient well hydrated, because usually these patients are a few days after the severe COVID. You would have gone past the high risk to kidney phase of COVID where we were recommending euvolemia. If they get into the mucor situation, we want hydration to be increased to make sure that the kidneys are not damaged under the amphotericin therapy. If amphotericin is not available, posaconazole or isavuconazole are the other two drugs that you need to look into for managing these patients. With the extensive experience of using amphotericin amongst HIV and other patients in India, the liposomal amphotericin, if you are having scarcity of drugs, should be preferentially chosen for people who have got renal impairment from before, and the normal amphotericin could be used for those who are young and with normal kidney function, as long as you're monitoring the kidneys regularly and hydrating the patient well. This is the reference of all the protocols that we have referred to in creating the slide set. So please feel free to look up and learn more if you are interested. So this brings us to the end of the section in medical management of COVID, including management of mucor. So I really hope that it has been useful for you and you've learned something and got more confidence in managing COVID patients. Next section will cover the pediatric management of COVID. Thank you very much.